just waiting for everybody to come in here now. The waiting room should be disabled. So yeah, it looks like everyone's coming through. Okay, fantastic. So thank you everybody for joining us today and taking an hour out of your busy schedules again, and welcome to the second EBME Expo webinar. I'm delighted that Rob Davies of ECRI has joined us today to present on using healthcare technology management tools to improve safety and efficiency. Just a couple of house rules as before. We will ask that everybody remains on mute throughout the presentation, just so that there's no distractions for Rob and he can move through the presentation as seamlessly as possible. We will be having a question and answering session at the end of Rob's presentation. I do ask that anybody who does want to post a question, please type it into the chat box. Please do include your name and organisation and the question. I will be reading the questions out to Rob at the end of the session. So please make sure that you do post the question to the group or to me directly. So yeah, once again, thanks everyone for joining us. And without further ado, I'll hand over to you from here, Rob.
Thank you, and welcome to the second EBME Expo webinar. My name's Rob Davies. I work for ECRI, based in the EMEA office here in the UK. Before joining ECRI 18 years ago, I worked at a large London NHS trust for 14 years within a clinical engineering department. Whilst I was there, I carried out many different roles, starting as a trainee technician and part of the management team when I left there. I am a registered clinical technologist, and I have been a full member of IPEM since 2003. Just to let you know, I am actually registered as blind. So if you see me lean forward or bob towards the screen, then it's just so that I can get closer to read the scripts, etc. We're going to have a quick look through the existing equipment management system and how it's evolved over the years. We're not going to go back quite this far. But some of you may remember, and there's probably potentially still some that are still doing paper records, filling up lots of cabinets around the department with equipment details, very simple basic equipment details, and handwritten job requests. During the 80s, personal computers became cheaper and more readily available. So people started transferring to computer-based systems, and that was really the sort of start of the equipment management system as we know it nowadays. This is a fairly common scene now of a common workbench in a department. You'll see that there's screwdrivers and soldering irons, but more commonly what you'll see now is a screen with a keyboard and mouse. And technicians will be looking up equipment details, recording maintenance history, plus they'll be looking up service manuals and ordering parts, etc. So this is a more common sight nowadays. The information that we're storing is also becoming more detailed. We're storing huge amounts of equipment information, history for the equipment, service history for the equipment over its full life cycle, detailed and sophisticated planned maintenance schedules for different events that happen to the equipment throughout its life. Detailed contracts for outsourced maintenance, making sure that we're quality assuring that and the vendors are delivering what they should be. And with the merging very much more so nowadays of medical devices and IT systems, we're storing much more in terms of IT information relating to medical devices. The way that we access this is also changing. There's obviously the traditional desktop computer, and we sort of merged onto laptops and netbooks. But nowadays, tablets and smartphones are becoming common items in an engineer's toolbox. So it's common practice nowadays for a field engineer, whether the field is out on the wards within a hospital or actually out on the road dealing in the community or amongst different customers. It's common practice for engineers to be wanting to update work order information, retrieve equipment details, etc. on their smartphones. And this is how we're accessing this data nowadays. We've been putting system or data into these systems for many years, and we've always taken it out, but the way we're taking it out is also changing. So there was obviously the traditional formatted printed report, and then people started putting it into spreadsheets, producing graphs, charts, and nowadays it's common practice to see complex digital dashboards with gauges showing all sorts of KPIs and data relating to maintenance and equipment and all sorts of things. So this is how things are changing nowadays. What do I see in the future? Well, I think there'll be and should be more connectivity and automation. Imagine your ventilator can automatically send you or create a work order in your EMS that says, I'm approaching my 3,000 hours service, please schedule this. A patient monitor, battery is failing, please order another one and we will schedule the system or we'll schedule the replacement of that within the system once it arrives. Infusion pumps, you've got a big group of infusion pumps, all need their software to be updated. Being able to push that down into the devices from a central location. Now, all of this equipment with the growing trend of telehealth, particularly in the situation we're in at the moment, all of this equipment is starting to appear in patients' homes. So being able to carry out things remotely is becoming more and more essential. The technology is there. It's common practice for manufacturers of large equipment like radiology equipment and radiotherapy equipment for them to remotely log into them systems and diagnose and carry out maintenance from a remote location. They might eventually have to schedule an engineer to appear on site, but they can make sure that the necessary parts are there, etc. So it is happening. It's happening with some of the smaller equipment as well to a certain extent. But what's happening is there is manufacturer-specific software that is all different, and it's different software for different manufacturers, different types of equipment, etc. So if we're going to get the real benefit from the potential that this can offer for engineers to be able to work remotely, then what we need to create is a standard for deploying software, for accessing devices. And that would require input from all of the manufacturers and vendors like ECRI of CMMS systems and EMS systems to be able to produce a standard so that we can get that efficiency. If we don't have a standard, then we're not going to get the full potential of being able to do things remotely, because engineers are going to have to log into different systems. They're going to need to learn different software packages to do this, and we're going to lose that or the real benefits of that potential. John mentioned in his webinar a couple of weeks ago about a vision of having clinicians in a central location similar to a control tower or an airport, where they're making clinical decisions remotely. I have the same vision for engineers, and I think, in contrast to the image that we saw earlier of a typical workbench, nowadays I think we'll start seeing scenes like this, and this will become the common workbench for engineers working remotely, monitoring systems, responding to alerts from devices, scheduling engineers to go out if necessary, deploying updates, etc. Particularly in the world that we are living in at the moment, this has never become more essential. Whether that's in a central location within a hospital or whether it's in a remote location, the technology is there to do that, but we need to get some standardization and start rolling it out to the more common portable assets rather than just the fixed assets. So we have sort of seen the more traditional way that an EMS is used by clinical engineering departments and biomeds, but the need for a system like this is now growing way beyond just the technical staff. Every healthcare organisation now has both internal and external auditors. They are measuring and auditing to make sure that equipment is being maintained, that it's accessible, it's ready to be used when it can be, to make it a safer environment for both patients and staff. So knowing what there is and getting that information out is vital for the quality and audit area of a healthcare organisation. Procurement departments, it's very common question for procurement to be asked, can you order me more of what we've already got? So it's essential that they get access to the EMS and the organisation's inventory so that they can see what is the most common make and model and reorder more of the same. Finance departments, it's their responsibility to maintain the capital asset register. That is traditionally, information for that is traditionally gained from purchase orders and invoices, not necessarily the best information for gathering details about specific devices. So getting information out of the EMS in the most efficient way possible to update that capital asset register when equipment is added or removed, then the systems update each other. Risk management. It's essential that the risk register within a hospital is maintained accurately. So it's essential that they know, the risk managers know what equipment is located in which departments, where it is, who's using it, what have we got, to make sure that the organisation isn't open itself up to unnecessary risks because they don't know what is within the hospital. User training. 25 years ago, I recruited an equipment trainer rather than a traditional engineer. It seems strange to be doing that at the time, but also felt the right thing to do. Nowadays, an equipment trainer, if they're not part of the clinical engineering department, they are very closely linked. It's essential that they prioritise the training that they deliver, and that's based on what equipment is used in what locations. So they need to know what is where, need that information out of that EMS. So there's many more areas around a healthcare organisation that can utilise this information that's stored in the EMS, and it increases that profile and makes this the real heart of a well implemented health technology management system. The way that all of these different people take the information out also varies. There'll always be the need for the user interface, logging into a device and retrieving information manually. Systems like the finance system create an interface between the two that automatically feeds that data in. So when something is added or removed from the EMS in terms of an asset, it automatically updates the finance system. It's much more efficient, very much more accurate than feeding that information in manually. Reporting. Whilst it's less used, there'll always be the need for a formatted printed report. And as we said earlier, the growing demand is for digital dashboards and showing it in gauges and charts and graphs and things in complex dashboards for monitoring of KPIs, etc. So an example of an organisation that has really taken advantage of this is the Health Service Executive in Ireland. They have adopted a national equipment management system. Their initial incentive for this was to be able to carry out national equipment planning for the whole country rather than on an individual hospital basis. By doing this, they have huge amounts of bargaining power and when negotiating the best deals with purchasing, because they're buying for an entire country, not just for an individual hospital. They can also improve on the standardization. So if you've got fewer makes and models of equipment, you can reduce your training needs. It's going to reduce your training costs. It's going to improve the or reduce the number of errors caused by people being unfamiliar with the many different types of the same type of equipment and different makes and models of it, all with their own little quirky features on them. So you've got the improvement there. Consumables, you're able to buy larger quantities of the same type. Again, with cost improvements, you've got better bargaining when you're buying bigger quantities, and you're reducing the risk of errors caused by the wrong consumable in the wrong device. So you've got great power there from improving on the standardization. Also looking at hazard and alerts management on a national basis is very much more efficient, and you get much more control by doing it centrally rather than individually in each hospital. And obviously running a single national system is cheaper than running individual systems throughout the country and individual hospitals. Obviously, these improvements will also apply if you're implementing a system in a smaller group of hospitals or even in a single hospital, but the impact is obviously reduced slightly. So how has all of this been put into practice? Well, in the last year, health technology management systems have been put under more pressure and have been tested harder than ever before in the last year with the COVID pandemic. All of these questions, I'm certain, have been asked at least once and probably many, many times by every healthcare organisation around the world. Having a well implemented health technology management system in place enables you to have the answer to all of these questions at your fingertips. So you can answer these questions quickly, easily, and you can give answers that are evidence-based and based on your systems that you've got there. So this year, these systems have been put under real pressure and have really been tested to their full. The benefits of a well-implemented system, we've looked at the training and potential cost savings and efficiencies that systems like this can bring. But I also feel that it has worked towards improving the exposure of the biomedical engineering and the clinical engineering departments. It used to be the guys down in the basement fixing the equipment, but they're now very much more involved and are getting the recognition that is well overdue for the work that they do. They are managing the heart of this system. They've evolved and developed the heart of these systems, and they're now getting involved in more areas around this. These systems are now reliant, many departments around the healthcare organisation are reliant upon this now. They are reliant upon the input of the biomedical engineers. So they're getting that exposure. With a system like this now, it used to be one department system. If it went down, never really had much impact on a priority list of an IT department. But all of a sudden, this system is now used by many departments all around the hospital. And if that system goes down, all of these departments are reliant upon it. So they need it. So it's now become a higher priority within IT. And I think this is helping to future-proof biomedical engineers. Equipment is becoming more reliable. So there will always be the need for bench work, etc., and repairs. But it's not the major focus nowadays. It's less about the maintenance and more about the management. So biomedical engineers, that role is changing. And I think all of this helps to future-proof those biomedical engineers that are coming in to the environment that we're in nowadays. So it's, as I say, more about the management and less, not nothing about, but less about the maintenance side of things. What I have talked about here today is what I think is the heart of a well-implemented health technology management system, and that's the equipment management side of things. but that's just one part of it. And there are many, many more tools that you need in your toolbox to be able to deliver a safe environment for patients and staff in healthcare. So you've got to make sure that you utilise them tools, provided people like ECRI that provide products and services to help with better procurement decision-making processes, better management of hazard and alerts, software to assist you with equipment planning projects and things like that. Some of these come in the form of products and services, but many of them come as free resources. So definitely make sure that you're getting access to them and finding those tools to make your life easier and to make it a safer environment for everybody within the healthcare environment. Thank you for your time. I hope you found it useful and beneficial. Please feel free to get in touch anytime if you've got questions or would like to discuss any of this any further, then please feel free to get in touch. I know that there's the opportunity for question and answers now, so happy to take any questions now, but please feel free to get in touch directly if you want to at any time. Thank you.
Thanks, Rob, for going through that fantastic presentation. I hope everybody enjoyed it. So I had a couple of questions posted to me directly regarding recording. So I can confirm that the entire presentation was recorded. We will be sending out an email to all registered attendees, providing them with a link to the presentation on our YouTube channel. And there'll also be a quick survey which would be incredible if you could take a minute out of your busy schedules to fill out, as it would be a fantastic feedback for us and Rob to let you see how things went and what you'd like from us moving forward until the EBME Expo takes place on June 30th and July 1st, 2021. So Rob, I'll move straight on to the questions. The first question that we do have is from Charlie Kirk. Charlie says, appreciate listening and seeing what you do, Rob. How can I introduce myself further into the NHS with what I offer?
Not sure what you offer. But within the NHS, if that's the direction that you want to go in, I'm not sure if you're a manufacturer or if you're a biomedical engineer. I would look at organisations, if you're a biomedical engineer looking at getting into the field and want to work within a healthcare environment, then I would look at organisations like IPEM, the Institute of Physics and Engineering in Medicine. They have a very good network, and that's exactly what they're there for, is for biomedical engineering. If you've got products that you want to promote within the NHS, then coming to an organisation like ECRI, who evaluate equipment and publish those evaluations on equipment, then that's a direction for you as well. And also, if you are looking at biomedical engineering and you want to do that, bear in mind that it's not just within the NHS. So you don't have to work within the hospital environment to be involved in biomedical engineering. I've actually been out of the NHS now for 18 years, but still very, very much involved in healthcare, etc. So there's many different avenues. So sorry, that's a very vague answer, but I'm not sure what it is that you're offering. So I hope that helps.
Thanks for that, Rob. The next question is from Craig Jameson from Addenbrooke's Hospital, Cambridge. Thanks for the interesting lecture, Rob. Craig's background is in building management, so he has experience with building management systems, BMS. Whilst there are clearly advantages to this idea as outlined, we did have additional workload with controller and infrastructure maintenance being carried out by a third-party supplier, meaning additional cost. Do you foresee this technology eventually being fitted to most medical equipment or only the more complex stuff? And has there been a cost-benefit analysis done on systems like the Irish hospitals to see what net benefit it brings?
Yes, I definitely see that there will be that connectivity with medical devices. The big fixed assets like radiology and radiotherapy equipment, that technology has been there for quite a while. Some of the more portable equipment has this technology built into it already and has had for quite some time. There are sort of portable ventilators that I'm aware of. It's not actually a practice that happens here yet, but there is in the US these portable ventilators that tend to be used in patients' homes are being monitored, etc., via GSM, etc. So that technology is coming into these medical devices. As John mentioned in his presentation a couple of weeks ago, all of this equipment is becoming connected to the networks for transferring of patient and clinical information and clinical data out of these devices. So they are starting to be connected to Wi-Fi networks in hospitals and hardwired in as well. So yes, I do see it increasing. It is increasing, but what it's actually being utilised for is not happening as much as it potentially could and probably will in the future.
Thanks for that, Rob. I'm just going to look for, just bear with me 1 second. Charlie wanted to just ask a follow-up to your answer in the first place. I'm just going to unmute Charlie so he can ask you the follow-up to the first question directly.
Okay.
So over to you, Charlie.
Hi, and thank you, Rob. And thank you, Jamie. Appreciate watching what you've done. I think from my, as you can see, probably from my logo in the background, I've set up a company that is dealing with how we actually combine the medical advice that we're given when we leave hospital and then the lifestyle that we live when we go home. So when you're given your bag of meds when you leave the hospital, which are all fine, but they don't know what happens when you go home and you might have a glass of orange juice, glass of wine, you have a smoke, glass of wine, whatever it might be, who knows. What I'm doing and what I've done is actually I've got in touch with the GMA, GMC, the RPS, but what I'm trying to do is actually get some more voice, if you like, in terms of how to actually get in touch with these people. I appreciate it might be not entirely your realm, Rob, and but I'm just trying to find out what the best way to go about with talking to the right people.
Yeah, I think you're going in the right direction. You're talking to those organisations. Yes, it's not my area of expertise, I'm afraid, but I think you've got to try the top-down approach, which is going to be with those organisations, etc., of which there are many, and probably trying to get into hospitals, which is going to be much more difficult nowadays than it was. It was already difficult before the pandemic. Getting time in front of people is very difficult. So I think it's going to be with webinars like this for the future is going to be your best way around it. But yeah, it is all about exposure, and that's why we're here today to sort of for the exposure of ECRI as well. We're not as we're well known in the biomedical engineering world, but we're much more than just equipment management systems sort of things. So I'm with you. We come across the same issues as well.
No, thank you, Rob. I really appreciate that.
So thanks for the follow-up there, Charlie. John Sandham has said thank you for the nod to my ATC reference, Rob, in the previous webinar. Excellent presentation.
Thank you.
The next question from Maya. My department looks after 3,000 patients in the community who are on long-term ventilation. We do a lot of companies offering different cloud-based systems. How can we get one NHS cloud where the NHS will be independent?
That's sort of what I was getting at in the in my presentation. That yes, all of these manufacturers, they all have their own software package, their own connectivity, and that takes away the potential efficiencies that we can have. And you've got to have these different systems. And if you're dealing with 3,000 patients, my guess is that you've probably got dozens of different makes and models of the same device type. And all of them makes and models, or certainly all of them makes, will have a different interface that you need to learn, needs to be kept up to date. And that's where I'm saying is you need an equipment management system, and we, and by we I mean ECRI, need to be working with manufacturers, and manufacturers need to be working together. I'd love to see a forum come together, and love to be part of a forum that would come together, that we can produce a standard, so that in a product similar to our AIMS system, you can go into there and you can access that manufacturer's equipment that you've got in the field, and you can see that in a standard portal. So that's what we're hoping for. There is an NHS network, there is the NHS net. So there is a network. I believe a lot of that is moving into the cloud now. So there is that secure NHS network in the cloud. But as a manufacturer, I know that it is very difficult. As an external vendor, it is very difficult to gain access, and it is incredibly expensive to have access to that NHS network. So if you're outside trying to access that, there are very, very tight restrictions for the right reasons. But that is what my vision is that hopefully we can produce something that would make your life of managing those 3,000 devices much easier from a single portal. And I would, if there's manufacturers here today that would be interested in working on something like that, then I'd be more than happy to coordinate and work on something like that.
Thank you very much, Rob. I believe I have a question coming from Farhang, who's asked for a question. I'll just unmute Farhang quickly so he can ask the question directly. Farhang, are you there?
Sorry, can you hear me?
Yes.
Yep, you're there. Great.
Sorry, I was talking to myself on mute as usual. Okay, this is really a broader question. We are currently engaged on an assignment with New South Wales Health Infrastructure Authority in Australia on development of an asset criticality assessment methodology and framework, which is joining up the dots between all assets, all equipment and technology, and all the associated equipment and services systems you could find in a healthcare settings, which includes IT, FM, as well as medical technology. A question for Rob, really, have you seen any kind of similar initiatives taking place where it's informing operational decisions that clinical engineers or FM engineers would be interested in, as well as informing investment and strategic decision making about what to replace, where to invest, where to put the resources into?
ECRI as an organisation have worked on a number of projects like this in terms of the equipment planning aspect of things. So yes, we have been involved in projects like that. I'm actually talking to a customer in New South Wales as well, in terms of an equipment management system. So I wonder if that is part of the same project that you're potentially working on. So we do work with a number of large organisations like that. We work with the state of Queensland in Australia, and they've adopted a system across the whole state as well for the equipment management. I think that there is more integration. I would say that there's less integration yet between clinical systems and equipment management systems. I think that clinical decisions in terms of equipment planning and things is very much more supported by the biomedical engineers, which are taking that data from equipment management systems. So I think it's going in the right direction, but it's very, very slow, unfortunately.
Okay, thanks for that, Rob. Moving on, we have, excuse me one second. Okay, so we have Joseph from Kenya. Welcome, Joseph, or Caribou. We have a question here from Chris Shepherd. You talked about the Irish healthcare system. Is there any published information about what they are doing?
Not that I'm aware of. It is something that we have discussed with them. And I must admit that I think the second question that I answered, I think it answered a similar question about whether analysis has been done yet. This is very much the Irish system. It's a work in progress. Around 2/3 of the hospital are on the national system so far. Whilst I don't think the project will ever be finished, these projects always go on, and there's always something left to be done. I think the analysis yet isn't quite there. So I think they are seeing the benefits. They have certainly seen the benefits this year with COVID, because the hospitals that are in there, they've been able to monitor those, see what's where. There's been a lot of movement between hospitals of different types of equipment as the specialities of hospitals have had to change to deal with COVID patients. They've had to move services like renal dialysis and things like that into other hospitals. So there's been a lot of movement of equipment, which we've been assisting them with, and shifting equipment around. So they've seen the benefits of it, but I don't believe, and I would be happy to find out if there's actually been an analysis yet of what the cost benefits and the efficiency benefits are of this yet. So the simple answer is that I'm not sure, but I don't think so.
Thank you, Rob. One more question here from Nabil Fatah. Thank you for the nice webinar. I am a biomedical engineer invested in a novel device for restoring sight. I am looking currently for a fund for making it commercial. By any chance, can ECRI help us for this?
I'm afraid not. That is a very common question. We carry out individual evaluations of equipment, but we are a not-for-profit. Because we carry out them evaluations, we're also involved in accident and forensic investigations. We have to remain very independent. So we cannot promote any manufacturers, any products or anything like that to maintain our independence, so that our independence or our evaluations are fair and independent. So we cannot promote any particular devices. We cannot be linked as an individual, as an employee of ECRI, and as an organisation. We cannot be linked or even have shares or anything within a manufacturer of a medical device. So my apologies on that. That's not, but please feel free to send the details of the device to our staff in the our US head office, who can retrieve information regarding other devices that are similar, etc., and possibly that we've done evaluations on.
Thanks for that. I think we have one more question here from Steve Constantine. Hi, we offer an equipment management system. Who is the best person to contact in a hospital to arrange a discussion?
My initial contact would usually be the clinical engineering department or biomedical department, because that's where it traditionally always has been. And as I say, they tend to be the drivers of a system like this. So that would typically be my starting point. But what we usually find when I'm demonstrating our equipment management system, we usually find that all of those people from my slides, so the risk managers, someone from procurement, someone from finance. I've actually done a presentation overseas where there was only 2 biomedical people around the table, but there was 10 or 12 people there in total. So they was actually the minority there. So it is changing, but that would generally be my starting point if I was promoting our product aims to do this.
One more quick question. I've been asked for a private a contact number for you, Rob, from here at Lane Fox Respiratory Unit. I would suggest that Hera can drop you a quick email and
yeah, my details are still on the slide there, so feel free to drop me an email and we can make contact on there, or our phone number is on our website. Sorry, I don't think of phones nowadays. You think of all the websites and emails, etc. So yeah, feel free to drop me an email. More than happy to talk. Or our phone number is on our website, and I think I'm on option 2, I think. So my extension number is 530. If you get the number on there. So yeah, feel free to get in touch however you wish to.
Another question here. I'm not quite sure who it's from. Sorry. Great presentation, Rob. Thank you.
Thank you.
Is it fair to say that manufacturers are developing their devices to report back for analysis? However, there is no one system developed that will collate this info across the board.
That's my understanding, that manufacturers are doing it individually. In true engineering style, the wheel is being repeatedly reinvented, and I think that removes our full potential of taking the getting the benefits of the efficiencies that this could bring. So that's why I would like to see a standard like the clinical data that's exchanged with something like HL7. I would like to see something on a technical basis that we can all work with, from manufacturers, EMS vendors, etc. I would like to see a standard, but it's my understanding that there isn't something there yet that is a standard across all device types and manufacturers.
Okay, Nigel, thanks, Rob. Great presentation. Just have to drop off for another call. I think that's it on the questions there. Oh, yep. Just a few more messages of gratitude, Rob. Thanks for earlier. I hope you haven't. have you had any experience in combining tech, apps, web, meds and lifestyle choices so people can have a view on their health?
I haven't personally, but ECRI has. It's something that's growing very much, and having your watch, getting an ECG on your watch is something that people desire nowadays. This is done both at a sort of low level on some you would buy on Amazon, but is also growing in the professional field and is being used within the professional healthcare environment. So it's something that we are doing a lot of work on. A medical device now, a piece of software can actually be classified as a medical device now. So this is very much changing, that an iPad all of a sudden can become a medical device that you're diagnosing with, etc. So yes, this is very much something that ECRI see as the future, and we are evaluating as an organisation, and we're doing work with and advising on as an organisation. But it's not something that personally I've had a lot of involvement with.
Wonderful. Well, thanks, Rob. Thanks very much, everybody, for joining us. As I said, we will be sending out the presentation via our YouTube channel along with the short feedback form on Monday. In the meantime, we'd be very grateful, obviously, if anybody could fill in our survey very quickly to give us some feedback and to give Rob some feedback. We will be in touch regarding our third EBME Expo webinar, which we expect to take place sometime in early December. Until then, thank you very much for joining us. Thanks once again, Rob, for a fantastic presentation. Lots of messages of gratitude coming through here on the chat. And have a wonderful afternoon, everybody, and see you all soon. Thank you.
Thank you very much, everybody. Have a good day.